This is Audible Bleeding, the Vascular Surgery podcast. We're here to help you keep your finger on the pulse. Welcome back to Audible Bleeding. I'm Adam Johnson, and today we have with us Dr. Jeffery Jim. He's the Associate Professor of Surgery and the Program Director of the Vascular Surgery Fellowship and Integrated Residency at the Barnes Jewish Hospital and Washington University in St. Louis. He did his training at UCLA for general surgery, then a vascular fellowship in St. Louis, and a master's in population health sciences in St. Louis. He's really an expert in comparative effectiveness in the treatment of vascular disease, and he focuses mostly on aortic disease and carotid occlusive disease, which is what we'll be focusing on most today. So just to get it started, Dr. Jim, what brought you to vascular surgery? What's a little bit of your background?
You know, when you start medical school, you really don't have an idea of what you're going to do. I really kind of gravitated towards surgical field. I really like the idea of sort of working in a big group as a team leader, be able to get pretty much instant results. You really kind of know if a surgery worked or not right away. It's a little bit different than, longitudinal care of a medical patient. In terms of vascular surgery, it's kind of random, just like most medical students, especially over a decade ago, really no idea what the field was. I was assigned at the VA. The vascular service was very busy, so I was like on the GI surgery service. They just needed a little manpower, so I got to go help out there. And when I went to the university service, I got assigned to the vascular service, and I really had a good time with the attendings. They had great cases. Pretty much kind of fell in love with it at that point, and kind of worked out ever since.
That's great. Do you have any particular mentors that pushed you in this direction or were instrumental in you getting to where you are today?
Absolutely. Definitely had important mentors. I think anybody who goes to any type of professional training will really owe it to their mentors for their success. So in medical school, I think most of you guys heard of the name Roy Fujitani. He was a vascular surgeon at my medical school, really somebody that was just loved universally by all medical students, be it you go into surgery or not. I rotated on his service as a third year, really kind of liked the way he was as a person, as a surgeon. He was great with his patients. He was very patient. He was a great teacher, very patient with students, fellows, ancillary staff. Just somebody that you really kind of model yourself after. When I went and wanted to do my sub-I, actually, trying to be a broad student, wanted to go ahead and did different experiences. He was like, no, you got to come back on the vascular service. So I got a chance to hang out with him quite a bit as a medical student. At the same token, at my medical school at that time, Dr. Peter Lawrence was actually a associate dean within the medical school. So he was also a big figure within vascular surgery. Got a chance to interact with him quite a bit as a fourth year student. And I think those two were probably the people that really kind of confirmed my interest in the field. And Dr. Lawrence particularly too. I like to joke around with him. He, when I went to residency at UCLA, he really missed the chance to train me forever. So he decided to follow me along and became the chief of vascular at UCLA. So obviously another 5 years of kind of being under his guidance and leadership, and that was really beneficial for my life.
So Dr. Lawrence has been, riding your coattails is what you're saying.
Yes, I like to think all of his success is really because of what I've been able to accomplish. So absolutely.
That's good.
And so what is it that you look for in mentees now that you're more on the faculty side and guiding trainees?
Yeah. I think for trainees, I think the most important thing is they just have to be really honest with what they want to do. As a mentor, my job is not really trying to create them in my mold or whatever I like, them to be. It's really important for them to be honest with themselves, what the goals and the career is going to be and the personal lives, and kind of blend it all together. Certainly the generic things of having a mentee that's willing to listen, they're actually seeking advice, to actually utilize the advice and be open-minded. I think that's really where the mentor can come into play, giving them, sharing our experiences, giving them advice, and a mentee that can really take into that and be honest with themselves what they want, are the ones that are ultimately going to be successful.
So the topic for today that I really wanted to pick your brain about was the transcarotid artery revascularization. Could you talk about how you got involved with that?
Yeah, sure. This all started several years ago. This is a procedure that was sort of developed with a homemade system and whatnot, and ultimately they kind of came up with a system to test in a clinical trial setting. At that time, Chris Qualluck and Rich Cambray up in Mass General, they were this sort of the national principal investigator for the clinical trial, and they were looking for trial sites. And at my institution, they wanted us to be involved. I was the one that had a particular interest in carotid stenting, had good results, was able to get good experience with that, and they sort of asked us to participate. At that point, it was kind of like, okay, this is a new technique. We're not quite sure what it is, but it certainly sounds interesting in concept and theory. So we became a clinical trial site, and I was sort of the local site PI for that trial. And subsequent to that, become quite involved with this technology, obviously completion of the trial, with their subsequent registry, and now in their education process for training other surgeons how to do this.
So can you give us a little bit of a background of TCAR, like why it was developed, maybe how you use it in your practice?
I think, for most people that have any exposure to vascular surgery, I think carotid endarterectomy is something that most students even are very familiar with. It's a really elegant procedure. It's been around 50, 60 years. It works great. It's a nice procedure that with excellent results. But as you sort of get to the nitty gritty of it, there are certain patients that are just not great candidates for CEA. And what that means is, be it there's medical risks, surgical risks that make them potentially higher risk for complications. So we've always been looking for an alternative for those particular subset of patients. About 20 years ago, over 2 decades ago now, they obviously started doing a lot of endovascular revolution, carotid stenting, which is done predominantly through the groin with the transfemoral approach. The results of that is sort of been debatable how great or equivalent it may or may not be. So it really has been something that was missing for this particular subset of patients. What's unique about this procedure really kind of builds on 2 foundations. One is, when you're putting a carotid stent, you do it right from the base of the neck, essentially what we call the transcarotid access. You go ahead, instead of starting the journey at the groin area, you go right at the base of the neck and deliver a stent from that location. So that's one aspect which leads to good results. The second one is the way you protect the brain during the procedure. It employs a reversal flow technique, which essentially prevents any embolization, and you try to combine those 2 things together to get good results for your patients.
So, Jeff, do you do most of your patients awake or do you do them under general? Like, what's your personal setup?
Yeah, so my personal setup usually is with a general anesthesia. I think it really kind of depends on the experience and sort of the institutional ability to do that. I think to be able to do things with awake, you have to have very good communication with your anesthesia staff. Your patients have to be willing to lay flat for less than an hour or so. For us at a teaching institution, not only am I teaching my trainees how to do this procedure, I also have people on the other side of drapes who are being taught as well, be it a anesthesia resident, be it a nurse anesthetist student. So it makes it a little bit easier if I'm able to do it in a controlled setting, general anesthesia for patients that can tolerate it, and I reserve the local sedation for patients that are truly at high risk for respiratory complications, for instance.
So when compared to either the transfemoral method or the standard surgical CEA, where do you use this in your practice? Which patients?
Yeah, so for me now, this is something that's really surprisingly taken over my practice completely. This is looking back at my data and my experience, I probably was doing about 20% stenting before this technology came about. Just about 1 out of 5 patients would have a high risk reason where I won't do a classic CEA, be it a restenosis, radiation therapy, or whatnot. Since TCAR became available, I really have sort of abandoned transfemoral stenting because I think that there's really not much of a place for it. And I was looking back, I was probably doing this about 60 to 66%. So about 3 out of 5 or 2/3 of the patients are actually getting TCAR now, and I'm reserving the other patients for the classic endarterectomy.
And so you said that you don't use transfemoral stenting at all anymore, really. What about your trainees? Are they getting trained for this from some of the other surgeons in your department?
We have a group of about 10 vascular surgeons. There's a couple that are still really diehard transfemoral stenters. I'll eventually, hopefully, be able to convince them there's a better way. But they're able to learn that from different attendings when they're obviously rotating on their services. In our institution, we're really the ones that predominantly do all the carotid stenting in our institution. There's no other places they can really learn that in. But I think overall, this is something that's probably low yield procedure in terms of how often they're going to be doing them in the future anyhow. I truly believe that. Transfemoral stenting has really limited use. So they get enough of an exposure. They may not be getting their full 25 experience of transfemoral like they were doing, 5 years ago, but they're certainly getting adequate transcarotid stenting now. And I think another question that was asked earlier also was, how do I decide who gets CEA, enterectomy compared to TCAR? I think a lot of it comes down to this is a great technique. This is a newer way, excellent way of delivering a carotid stent. I think the bottom line, though, the algorithm of how you decide to treat a particular lesion really hasn't changed in the sense of the lesion characteristics. So there are just some lesions with so much calcium and disease that a stent is not really the best option. We know that if you sit there and put a metal stent against a calcium chunk, give it about 2-3 years, usually the calcium always wins. So I think lesion management, looking at the characteristics of the lesion you're trying to treat, that's still something that predominant factor in deciding, is this a really stent candidate, be it transfemoral or transcarotid.
We've all heard that there's some anatomical limitations to the TCAR. Can you go over those and talk to us about some of the pitfalls of the procedure?
Absolutely. I think it's a great procedure, but you have to fit the right anatomy. So, we know from, for instance, endovascular aortic experience, right? If you fit into the instructions for use to IFU, your results are going to be a lot better. You start getting, not so great results long-term when you start pushing an envelope. In order for a patient to have the anatomic criteria for a TCAR procedure, you basically have to have a good access site to be able to put in the sheath at the base of the neck in order to treat the lesion. The goal of this for all carotid treatment is to not touch the lesion until you have protection. So you need about a 5-centimeter landing zone is what we call it. So you have to, from the access site all the way to the lesion, you have that 5 centimeters. And the reason for that is that's just the way the sheath is designed. You got about 2.5 centimeters for the arterial sheath within the lumen. You have a little bit extension with the dilator and then subsequently the wire. So you really need that running room to be able to safely get access. So that's one of the biggest things. The other one that's probably really important as well, as we talked a little bit about calcification, not just of the lesion you're treating, but of the access site. So we got to go ahead and access the common carotid to be able to put in a sheath safely. So if you have a lot of disease in that area, you're not going to be able to go ahead and put in a sheath without potentially embolizing. So that's a contraindication. Same thing if you don't really have a place to clamp or occlude the artery, because in order to get reversal of flow, you have to arrest the antegrade flow from the common carotid. So that's really the limitations in terms of what you can do. Aside from that, there's things, obviously, if you have a laryngeal stoma from a laryngectomy, you really have to find a way to make sure there's no colonization from your surgical incision. But I think the biggest one is the anatomic criteria that I mentioned earlier.
And like many things in vascular surgery, we tend to get these initial, IFUs, and then they end up being pushed. Or are you pushing those with TCARs?
I think that's a very good question. I think one of the things that as a practitioner that's doing this and also responsible for teaching new surgeons how to do this, I definitely tell people don't push the envelope. This is a great technology. You get excellent results. And I think it's, for me, again, it's sort of the majority of my patients now. But, the alternative a lot of times is also pretty dang good, right? If you can't get a TCAR, a lot of times is, you get a CEA, and we know the results of that has been excellent as well. So I think, you don't really want to push the limits, because obviously, it's not really talking about endograft failing potentially 5 years down the line. You're talking about perioperative stroke, which is obviously a big deal.
So Jeff, obviously you've got probably more experience in TCAR than most of the users out there. And, like with anything, there's always a learning curve. Is there any special technique that you figured out along the way that's gotten you out of trouble or simplified your approach that maybe is not in the training?
Yeah, I think certainly as the training has evolved, and this is actually one of the things we do, we continuously update the training, because we really, at the beginning, was really kind of figuring out how to do this. I always like to joke around with the people that come to the course. One of the reasons they probably asked me to teach is because I was the one that screwed up a lot at the very beginning. You just go through and you're trying to figure out how to retract the artery, you do it wrong, and you cause dissection. A lot of it's because we just didn't know. So I think nowadays we're actually doing a pretty good job of sharing our knowledge now. So when we give the course to be it trainees that come to our course on a yearly basis or practicing physicians, we really kind of share with them experiences, really try to make it streamlined. So I think now everything that we teach in terms of minimizing the exchanges, really coordinated movements, making it simplified, I think just putting the sheath in was one part of it. As we've gotten more experience, we've also had sort of different recommendations of how to actually do the procedure in terms of putting the stent and ballooning. The lesion management's a little bit different, and we also started focusing on how to actually pick the right patients. I think for the longest time we were just really focused about how to do the procedure, but now we've kind of extended it a little bit to make sure people pick the right patients, so when they do the procedure, there's a good technical result.
And so something that's been really interesting about the kind of evolution of transcarotid stenting is the data that's available and how the research has been progressing. There's 3 articles coming out this month or over the next few months in press about updated data on outcomes related to TCAR, and we'll put links to those in our show notes. One is a 1-year update to the ROADSTER trial, so the prospective clinical trial. Another is data from the SVS VQI registry, and then one that you were involved with is multi-institutional data. I wonder if you could talk a little bit about the data that's out there, how people should interpret these different studies, the strengths and weaknesses, and where do we go from here?
Yeah, I think the timing just happens to be perfect. We're doing this at this time, just because when the technology came about, you have the clinical trial, and then subsequently you have it FDA approved, and then they go through some regulatory type things to get reimbursement. So I think just everything's sort of coming out about now, just because that's when we be able to gather a little longer term data. I think as always, when you look at clinical trial data, which is essentially the ROADSTER trial, when you mentioned the 1-year results coming out. Those are obviously very selective patients. So it's great. It's important to have that because ultimately it demonstrates proof of concept that you can do this procedure safely. But I think, from talking to a trainee standpoint, these are very carefully selected patients. You have to fit a criteria, and that's the whole concept of clinical efficacy, right? You're taking, patients that you select them within a particular criteria with a lot of maybe exclusion criteria that will exclude a lot of your patients in your practice, and you follow it and you take only just experts doing it. So not to say data is not valid. It certainly is, but it just may not be something that's applicable to the whole world. So I think when you look at clinical trial, that's something you have to look at. And it was great to be able to get some longer term data because obviously, carotid, we've always looked at just 30 days as outcome perioperatively because we know that's when most of the issues, the adverse events will happen earlier. So it's nice to be able to have that as a complementary piece to be able to say, all right, if you follow these patients a little bit longer, they do real well. I think the real things that we want to look at is what's actually happening in the real world, right? Besides just a clinical trial. So that's the multi-institution study that I was a part of. That's with led by Vic Kashyap up at Case Western. And basically we just took our institutions, look at we were doing CEAs and go ahead looking at TCAR and just really kind of try to compare the results. So obviously you want to give a little bit more credence to it because these are people that we were just taking care of. I was selecting them out of a clinical trial. Obviously 3 institutions with a short period of time is not going to be as powerful because you can say, hey, that's 3 high volume sites. They're not going to be able, they're pretty unique people with the system set up. I think the VQI is probably the one that's really everybody's excited about. So I think everybody's listening to the podcast probably knows a little bit about the VQI is. It's essentially a registry that anybody can sign up for and put in data. What's really unique about the TCAR surveillance project is basically everybody who does a TCAR, if they want to get reimbursed, and that's a huge thing obviously for physicians doing procedures, you're going to input your data. So the data that goes into it is really from, it could be my 100th case that I did, or it could be somebody else's first case. All the data is collected. So that's really a real world type effectiveness, looking at it in terms of how people are doing, people that we're actually treating in the country. So I think that one certainly has a lot of excitement in it because it's also a bigger number, right? You have this small clinical trial, you have the 3 institutional series, and when you finally look at it, this is obviously a lot more patients getting TCAR, going ahead and getting it done. There's actually one more publication that's there, I think they're working on too, is specifically looking at transcarotid stenting versus transfemoral stenting. The one that you mentioned was really comparing transcarotid and transfemoral. If you look at the data, it really clearly shows that transcarotid stenting has much better outcomes than transfemoral stenting. What was actually nice in hopefully the data that's already been presented at the VAM last year and hopefully become a manuscript format pretty soon, is looking at transcarotid stenting versus CEA. And what was really powerful was that the 2 procedures are exactly the same in terms of outcomes. The stroke and death rates are about the same, no statistical significance, and everybody seems to do real well, which is kind of what we were hoping, and people that know this procedure wanted to make sure that's the way it is.
And you touched on this a little bit with the VQI registry, but are you at all concerned about the unintended consequences of kind of wider adaptation of this?
Yeah, no. So I think one of the things is, absolutely. But at the same token, it's great for all of us to sit there and say, keep citing data, right? Oh, look at the ROADSTER, it's 100 something patients, people do great. But when it's said and done, though, if you're not going to be able, as a vascular surgeon, bring it to your patient, then really what good is this technology? So I think certainly having to be able to include everybody could potentially lead to bad results. And that's probably why in our training course, we're really very carefully selecting physicians that have, experience taking care of carotid disease. We're not really, training people who've never done carotid surgeries, taking people with experience of dealing with this, and then ultimately teaching them, hey, this is a great technique, but honestly, use it smartly so we can get good results, so we can keep having this technology around.
And then I have a question, if there is this massive shift towards favoring endovascular repair over the open repair, what do you think might be the long-term effects of this, 10, 20 years out for these patients?
Yeah, so I think this is definitely a shift, and when you look at it, what's sort of nice now is because we've had like the CREST trial, the ICSS out in Europe, you actually be able to follow these patients a little bit longer. Because you're right, when we throw in a stent, if you look at, like, for instance, lower extremity, we kind of know that stent works pretty well up front, but it may not last as long term. So that's always something we think about when we talk about carotid stent versus carotid endarterectomy. But if you sort of really dive into the data, even looking at a CREST, which again is a clinical trial, sort of comparing everything, if you look at the restenosis rate, in terms of either arm, CEA or stenting, it's about 6% in 2 years or equivalent. And if you follow the published paper, I think it was a year and a half ago, it came out looking at sort of 10-year follow-up for CREST. If you look at the survival curves or the Kaplan-Meier curves up to 10 years, they're pretty equivalent except for the very beginning. So it tells us that if you're able to do the procedure, whichever way it may be, either showing in a patch or putting a stent in, if you can do it really well up front, it doesn't really matter long term. The potential recurrence rate, the reinterventional rate, many years down the line, is actually equivalent between the two modalities. So if we can figure out a way of doing the carotid revascularization procedure well up front and minimize that perioperative stroke and death rate, then the long-term results should be very similar.
So I think this has been a fascinating discussion of, the different treatment modalities for carotid disease. What skills did you develop during your training that you think are helping you to be successful in your comparative effectiveness research career?
Yeah, I think certainly being very up to date with reading literature and not just looking at the data like we talked a little bit about earlier, really getting a good understanding on a certain subset of topics. So my research interest has always been looking at aortic aneurysms, carotid disease, so really know the literature, and more importantly, understanding the strengths and weaknesses of both types of studies, be it clinical trial versus comparative effectiveness. I think for me, I was able to be lucky enough to take a little bit of time during my early years as an attending, really kind of make myself some time, half a day every week, to be able to take some coursework to get really a more additional time to really think about these topics. So I was able to get a master's degree that was actually offered through my Department of Surgery here. We have an excellent Division of Public Health Services here, which is rivals some departments across the country, where they have a degree program where I was able to just hang out with a bunch of people that are not surgeons, not necessarily clinicians, and really kind of understand research methods, analysis, clinical trial design. So I think that was immensely important for me. The other thing is just surround myself with people that really do this type of research and sort of pick their brains a little bit, right? When we go to science meetings, I still do the same thing, where obviously just like everybody else, I will listen to some talks. But if somebody has, a good presentation, I would go pick their brain on something, not necessarily even about the topic they just presented, but the methodology, how they think, and really I think pick up a lot of that just from, interacting with other people way smarter than I am. And if I can just get a little knowledge from them, that's obviously very important.
And so something else that you've worked a little on is cost and how that factors into the comparative effectiveness of different treatments. Could you define cost for our trainees and how that might affect them and their careers in vascular surgery?
Yeah, absolutely. I think for most of us that have worked in a hospital type setting and practicing surgeons, we sort of see this a lot. And I think you guys will probably see it more and more, being exposed to it as trainees. When you're sort of a junior trainee, you just kind of put your head down, take care of stuff, and that's, learn it along the way. But as you get a little bit older and get more mature in your training, you start being exposed to some of the other aspects of medicine, in this particular case, the business of medicine. Obviously, healthcare costs is something that's a huge topic within the country, within obviously the medical world. I think vascular surgery is has a big role to play in that because, a lot of the stuff we do costs money with devices that are expensive. We're not just talking about simple things like how many days they spend in the hospital, whatnot. So I think one thing that I kind of really emphasize in my trainees is, look, you really have to be involved in cost control at your institution, really learn about it, because if you're not at the table, somebody will make those decisions without your input. And you want to be able to kind of guide them with medical reasons why you want certain things. So I think for cost that we're looking at is actually cost of devices. How much does it cost to be able to do a procedure? Is this really beneficial for the patient, beneficial for the health system? Is it going to be able to be beneficial for the hospital system? Because if you bankrupt them by doing these $1 million cases all the time, that's great for the one or two patients, but if you shut down the whole system, that doesn't work as well. So I think those are kinds of things that are really important. For vascular surgery, device cost is probably one of the most important things that we look at. That's maybe different from some other fields of surgery, but certainly within the field of surgery, how many patients are being readmitted, unexpected return to the operating room, all those kinds of things are going to be important for looking at cost.
So you obviously mentioned devices as a major driver in cost in these surgeries. Can you touch on what other major drivers there are? And then secondary, a lot of these devices often advertise their cost effectiveness by saying that they'll speed up your operative times and counterbalancing the cost of an OR, which everybody estimates, at hundreds of dollars a minute.
Yeah, so I think some of those, it's a matter of, for instance, we just went through this as a big thing at our Barnes-Jewish hospital system, our Barnes-Jewish consortium system, where about, I think, a dozen hospitals, whatnot, and we were looking at aortic endographs. Obviously, as a surgeon, we all have particular likes and dislikes of different endographs, but when it's said and done, they all work pretty well under the IFU, right? Because clearly you pull open a JVS, there's all these articles that everything is 99% 5-year freedom from something horrible. So when you look at it, how much is a newer device with that costs, so much percentage extra worthwhile longer or not? So you have to kind of really put those things into play. Work with the industry partners, right? Is there any way to kind of streamline it, maybe purchasing as a big unit instead of single hospitals? So those are things that we're looking at in terms of cost to try to figure that out, if we could improve it. Aside from that, obviously the hospital is very interested, as you guys probably know, MI, COPD, heart failure, in terms of insurance reimbursement. If a patient comes back into the hospital within 30 days, you're not going to get paid for them, or you may potentially even get penalized. It depends on where you work. Medicare dollars is a significant portion of the overhead. So without all that, those are all things that you have to kind of think about in terms of looking at cost control and basically cost maintenance.
Jeff, do you have advice on people in terms of partnering with an administration in order to give the care that you need for your patients while controlling costs? Like, what have you found works for you?
I think the thing that works is, having some patients working with them. I think a lot of times they want the best for the patients too when it's said and done. I know the easy things to say is, no, they're just looking at a bunch of numbers. No, I don't know if that's always a fair statement to make. They just really need to have a good understanding of what's going on. And you as a physician, you really do understand the nuances about different devices, why something works better. So if they ask you to explain something, just be available for them. Really take the time to explain, what the difference between a thoracic endograph versus an endovascular, abdominal endograph, because a lot of times they were like, well, why come sometimes these cases you use one piece and this other thing you use three? And that's, well, that's a whole different part of the body. A lot of times there are just business persons that don't really have an understanding of the medical component of it. Partner with them, explain to them, explain the data to them, right? Again, like you mentioned earlier, how if they're just looking at the cost of a procedure, they're just going to look at the receipts when it's said and done. But like you mentioned, when we could do a TCAR that's easily an hour or longer or shorter, they're going to be able to utilize that time. And one of the things that people tell you is the most important and most expensive thing in the operating room is time in the OR. So you need to be able to bring that to the administrator and say, listen, if we do this procedure, even though the cost, the profit margin is not significantly changed, we do more of this because you actually have an extra hour per day or 2 hours per day to do additional cases, make everybody a little more efficient. So I think just being at the table, being patient and explaining things, I think they're actually very receptive of that.
And that's worked for you in the past, the approach of saying, well, bringing this new technology, even though it's initially a little more costly, will result in overall more efficiency.
Absolutely. I think the other thing too is you have to be upfront and say if it turns out to be not efficient, not better, you have to be able to accept that as well. So similar to what they were saying earlier, right? We have this TCAR surveillance project. If the results aren't good, you got to own up to it too. Luckily, everything's been working out. So when I go back to my administrators, if something's not working, you have to be able to sort of, say, all right, that's fine. It's not working. Let's move on. But you can't sort of stick onto it. If you're spending all this time talking about costs, you have to kind of look at the results when it's said and done too.
And then on the flip side, you've written a little bit about the workload and kind of the increase in volume for vascular surgery. And wondering if you could comment about how maybe trainees could prepare for the increasing clinical demands in addition to these administrative and cost demands.
Yeah, so one of the things that I've always sort of been interested in, I think started a few years ago when I was a trainee, I was just looking at, a lot more people getting older, the baby boomers. I think at that point when I first looked at this was just turning 65. You have an older population that tends to live a lot longer than they used to with really sort of sick comorbid conditions with a lot of vascular disease. And I was wondering, like, who's going to sit there and take care of all these people? Because we have the same amount of trainees being created. So one of the things that obviously, as you know, Dr. Macaroon and his work as SVS president is really looking at workforce issues within the United States for vascular surgery. And I think for a trainee coming out, the good thing about it is you're pretty much always going to have a job, so which is always nice. But at the same token, if everybody wants to work at beautiful New York City, there's only so many jobs. So it's not that everybody can go there, but you're going to be able to get good experience getting a job. I think, knowing that you have a lot of opportunities, when you come out and practice, maybe collaborate with others, maybe have different models of where you work. Is there going to be some system where other hospitals will contract with you guys to send you patients for certain things only? Are you going to work in a multidisciplinary place where everybody shares the work so you get a little more efficient? So I think those are sort of the immediate impact that people may be able to feel. In the bigger societal picture is we got to find a way to get more people interested in our field, kind of exactly what you guys are doing with the podcast, right? Get more people excited about what we love. Get them well trained and go out to join the workforce to take care of people, because Dr. Lozzi and I are going to get old enough pretty soon. We'll need people to take care of us.
Speak for yourself.
That's been a great discussion, Dr. We have a couple questions that we like to kind of finish these things out with. The first of which being, what's happening in vascular surgery that you're most excited about right now?
Wow, I was going to say, we spent about 30 minutes talking about TCAR, so I really can say that as an answer. I mean, I think that's something that's been a big change. I think obviously the other thing is as have improvements and new technologies with treating aortic diseases, I think the arch and branched technology is pretty exciting. That's always been sort of a very challenging area for us to deal with, and as we're getting more newer devices, as they get better, that may be an option for patients that are otherwise not able to be treated. We're lucky to be the site. I have a new double branch arch device recently that's been testing. So I think it's very exciting to be able to have newer technology. And that's one thing I've always really loved about vascular surgery. We always have new technological advances that's it's going to kind of keep pushing the field forward to be able to take care of patients or sicker patients, and hopefully a less invasive way with less complications.
Do you listen to music in the OR? And if you do, what kind of music do you listen to?
Well, what I like to listen to, what I actually put on, is probably a little different. So, growing up in the West Coast in LA, people always make fun of my little West Coast rap music that I put on.
There you go. That's the best operating room music ever. I have to agree.
It is now, but I gotta say though, so we always make sure we get the Pandora version that's clean.
Yes.
There's no bad words. Snoop Dogg really has a lot of silent moments, but it's okay because that's when everybody's happy. I don't have to get the hotline called on me, so that's usually the type of music I listen to.
And then is there anything within vascular surgery that you believe to be true that most people might disagree with you on?
I don't try to have some weird thoughts that are so different than everybody else. But I would say the thing that I really truly do believe, and that's a little shout out to one of my other mentors. So I forgot to even mention this at the beginning. So when I was a resident, I was actually assigned a mentor throughout general surgery residency. And that mentor was Dave Rigberg. So at some point, he actually listened to this podcast. So I figured I better
super enthusiastic as a mentor.
Super enthusiastic as a mentor. And I always like to joke around. Despite having Dave as my mentor, I think I did okay. So, him and I always think, I think the thing that's really, I want everybody to understand that at some point, Dodgers are going to win the World Series. We're getting really close. And it's been a very painful October for a couple of years. But I think that's the truth that I believe in, that we're going to win the World Series at some point. That I don't think anybody else believes in, but I'm for sure know that's going to happen soon.
All right. And then just in general, anything else that you do in your free time when you're not operating and doing vascular surgery?
Aside from driving the kids to gymnastics meets.
Yeah, I was gonna say my lovely wife is obviously been by my side for a long time, and I think she does the bulk of the work. But I think we have three beautiful children. Twins are 11 and a daughter that's 9. Actually, as we speak, my wife is with one of them. Traveled the little one to gymnastics meet at Hilton Head, so I'm hanging out with the twins at home today. So I think that's pretty much what I do now. I joke around. Back in the day, I probably had things I like to do. Now I just sit there and hang out with the kids. We watch a lot of sports, obviously Dodger baseball. I am an SC guy, so my Trojans aren't doing so great, but we try to watch that as a family when we can. And really just that's kind of it, just kind of keeping the family float, and doing those kinds of things.
That's great. Well, Dr. Jim, thank you very much for spending the afternoon with us. Some great discussion. Do you have anything that you'd like to throw out there to close us out?
No, I think what you guys are certainly doing is great. I think it really gives exposure to our field to different people that listen to the podcast. I think for all the medical students out there, PMed and other residents, I think, vascular surgery has been something that I was very fortunate enough to fall in love with. Just like I sort of mentioned, just happenstance, I got exposed to it. I think what you guys are doing is great. Really kind of share all the fun things that we're able to do. And glad that you guys invited me and really appreciate it.
We are Audible Bleeding, the vascular surgery podcast. You can find us on social media at Audible Bleeding or online at audiblebleeding.com.